So this is a very important chat that we are going to have. So feel free to invite your friends and family members because we are going to have a lot of fun and interesting discussion going on. So for those of you who are meeting us for the very first time, I'm Dr. Shobha Rayapudi, and this is my husband, Dr. Arjun Rayapudi. Both of us, we co-founded Gift of Health, where we actually help people struggling with chronic diseases, including but not limited to high blood pressure, high cholesterol, diabetes, heart disease, and common chronic conditions that we see nowadays. So we help people struggling with those to gain freedom from them, reduce their dependency on medications, and have more energy through better diet and lifestyle. So, as a lifestyle medicine doctor, we help people to make that lifestyle change which they are unable to make on their own. So, welcome everybody, and we are so excited that you guys are here. Like March is Colon Cancer Awareness Month. And we thought, what could be a better way to kick off this call by like talking about colon cancer? Unfortunately, colon cancer is the second leading cause of death. Like if you are in Canada, it's it's the second leading cause of death, and if you are in US, even colon cancer is the second leading cause of death. Every day, unfortunately, like around 142 people die of colon cancer. If you're living in US and in Canada, 142 people die of colon cancer, and like around 450 people are diagnosed on a daily basis. If you are in US, 1 in 20 people are diagnosed with colon cancer, whereas if you are in Canada, 1 in 16 people are diagnosed with colon cancer. So as you can see, like this is something that we are seeing so commonly. But the thing is, this is something that is preventable. And that's what we are here to talk about and raise awareness about. And to help us do that, I have two wonderful people here. So many of you know Dr. Arjun. And this is something he sees in his clinic on a daily basis. And I'm also joined by a special guest today, Dr. Vani Paleti, who will be joining us shortly. So I'm so excited to have both of these folks here because this discussion is going to be life-changing and it can save lives. So that's why feel free to invite your friends and family members. So make sure you share with all your friends and family members.
On a daily basis, I see several patients with colon polyps and colon cancer. That's my routine work.
Yes. So like how many patients do you see? Like how many would you say? Either on a weekly basis or a daily basis? How many cases
You
of
mean colon cancer?
yeah, how many cases of colon cancer do you see?
Yeah, see, we are in a small hospital here in Buren Hospital. It's a rural, like a medical center, right? Even for a small hospital like this, I see at least 1 to 2 colon cancers a week, and sometimes more than that. Yeah.
Yeah.
Dr. Vani, are you able to hear us?
I can hear y'all. Can y'all hear me? I just want to make sure.
Yes, this is much better.
Yeah,
okay.
So
okay.
glad.
Okay. Awesome.
Yes. So welcome, Dr. Vani. And we are so excited to have a Dr. Vani here. And as we said, like March is Colon Cancer Awareness Month, and we couldn't be more happy. And it's such an honor for us to have Dr. Vani here. So she is a board certified gastroenterologist. She is also certified in lifestyle medicine and obesity medicine. And if you look at Dr. Vani's profile, like a lot of you may also see her as the gastro mom. So that's a cute little name. So, and as I said, so besides practicing gastroenterology and lifestyle medicine, like Dr. Vani, she enjoys spending time with her family, with her pet dog and cat. And the interesting fact about Dr. Vani is, like, do you guys know she was able to actually hike Mount Kilimanjaro? And also, like, she is a practicing physician in Texas, and she also hiked Grand Canyon rim to rim in one day. So you could see, like, you could see all the plant-based power and everything that, like, Dr. Vani brings. And it's a huge honor for us to have her in today's Total Wellness chat. So welcome, Dr. Vani, and it's such a pleasure to see you and have you here.
Welcome.
Thank you so much. It's been a while since I did a live, so I'm like a little nervous and anxious as to how things are going to pan out. But I am so honored to be here with Doctors Arjun and Dr. Shobha for the Gift of Health. And the work that they do is they do this work without expecting anything in return other than wanting to educate their community as well as their patients to lead healthy and sustainable living, which is kudos to y'all. And y'all are part of my inspiration. And I'm very, very happy to be here. And I know Dr. Arjun was having a busy schedule. However, being that he's a surgeon who takes care of colon cancer patients, we really wanted him to be here. And I'm so thankful that you could make some time for us today. And all that's said and done, I did hike Grand Canyon rim to rim in one day, but I struggle a lot. So there's a lot that I need to like work on too. So that just for like transparency, it's a very hard task and we need to train, but I did struggle. So that is something that I just want to make everybody understand that, yes, everybody has limitations and we need to train and make sure we check off the checklist that we all want to, because all work and no play is not going to make anybody happy and productive. So saying that, I would move on to today's presentation, which is very close to my heart because I'm a gastroenterologist and colon cancer is something that we all need to talk about, just as how we talk about breast cancer prevention, just about how we talk about diabetes, about disease process such as heart disease and obesity. Colon cancer is also something that we need to spread awareness. And March is an colon cancer awareness month. And what best time and month other than talking about it today? Can I go ahead and share my presentation?
Oh, yeah,
Yeah.
absolutely. Yes,
Yes.
yes. Yeah.
Yeah.
We have Neelam Patil joining from Minneapolis, Minnesota. And we have Vanessa. Welcome, guys. And feel free to share any questions. Also, invite your friends and family. Okay, so as I was mentioning, this is something that I see every day, the colon cancer, working in Newfoundland. As some of you may not be aware, that Newfoundland has the highest amount of cancer, colon cancer, like percentage wise, compared to all the rest of the provinces in Canada. And even I was surprised when I started working here in Burin Peninsula. Like I did my training in US and India. I was seeing patients who, younger patients who with the colon cancer in their 40s and 50s, like, and I was also seeing aggressive, more invasive cancers in 40-year-olds. It was quite surprising for me. I didn't see such onset of early onset of colon cancer while I was working in US and in India. Later on, I was able to make the connect. I was able to connect the dots and see why there is so much colon cancer here. That's what we'll be talking about. All the lifestyle factors, how some of the simple uh, lifestyle things that we don't take seriously could be increasing the risk of colon cancer. What I found here, one is like in Newfoundland where I'm working, it's uh, it's like a number one, like compared to rest of the provinces. In US, you call them states, but in Canada, we call it provinces. Number one, like compared to rest of the provinces in colon cancer incidence wise. And I was also seeing like cancers in younger patients, colon cancers in patients who are like 40s and like low 50s. And metastatic as well. Like I've had 40-year-olds and 50-year-olds presenting the initial presentation itself, like stage 4 colon cancer. And unfortunately, fortunately, I've been able to help many patients, like by diagnosing them early and like doing surgeries and all. But unfortunately, I had to tell hundreds of my patients where there is not much we can do like surgically, and had to send them for like palliative care or just chemotherapy to slow down the progression of the disease. So it is heartbreaking to see people struggling with a disease that, if you look at the science and the connection between the diet and lifestyle and the colon cancer, we have some pointers pointing towards how eating certain foods can lower the risk of colon cancer, and eating certain foods can increase the risk of colon cancer.
Yeah.
So I think since you have your presentation up and there, like, why don't we just, you can do the presentation and then we'll circle back and we'll talk more about it, Vani.
No, okay. So let's get started. I just want to make sure that I don't have any financial disclosures, and also the resources that I have looked into and all the slide deck are either from American College of Gastroenterology, and I've posted a link which will take you all to the physician portal, patient and physician portal, and you can get all the information about colorectal cancer, about colonoscopies and the tests. Those are available. And the next site is the American Cancer Society. And also I have put in a link for a podcast from Gastro Girl, who compiles a lot of digestive disease digestive disease podcast, and it's all in one place. So and it's all evidence-based. So if you need to like hear about colon cancer, bowel prep, colonoscopy, bowel prep, or colon cancer, when to start screening and whatnot, you can go to that particular site. And as I said, there's no financial ties or anything. I thought it's very informative and patient-friendly. So those are the places that I have collected the resources for today's slide deck. So why are we talking about colon cancer? And as Dr. Arjun rightly mentioned, colorectal cancers are rising more so in younger population, and they've become third most commonly diagnosed cancers in both men and women. Remember, colon cancer affects men and women. Anybody who has a colon, you are at an increased risk, or you are at risk for colon cancer. And that's where the whole thing of prevention and screening test comes into. There's nothing like colon cancer is going to selectively affect only the males or the females. As long as somebody has a colon, we are at risk for developing colon cancer. And colon cancer is now becoming the second to maybe in few years be the leading cause of leading cause of cancer deaths in both men and women. So you need to understand it's most commonly diagnosed, third most commonly diagnosed, second leading cause of cancer death, and at some point in time it might overtake and become number one leading cause of cancer deaths, male and female. And the interesting thing is colon cancers are preventable. For most part, they are preventable, treatable, and curable. And the thing that we need to understand is when we talk about preventable is there are screening tests available to make sure that, hey, at this particular age, can we screen for colon cancer? That's one thing that we need to understand. And the second is know your body, because as we are talking, we keep saying that colon cancer is occurring more and more in younger population. And if I'm not at an age of screening, because the screening 3 or 5 years ago was recommended at the age of 50. And as we started seeing more and more younger patients coming in with advanced colon polyps or early colon cancer, the task force, US Preventative Task Force, kind of brought the age down to 45. And we've been like screaming on the top of the mountains and the top of our voice saying, 45 is a new 50. So the screening age has been dropped down for average risk patients from 50 to 45. So there might be like, oh, but you're saying that we are seeing more and more colon cancer patients between 35 and 45, and I am not at an age where I can ask for screening. And that's where you need to understand, know your body. Like if you have any alarm symptoms, like there's a change in your bowel habits, either you get constipated, there's a change in the caliber of your stool, you've started noticing any blood in your stools, or you've started noticing unintentional weight loss, abdominal pain, all these are what we call as alarm symptoms. So if you see any alarm symptoms and you're concerned, talk to your primary care to see, hey, is this something that requires referral to a gastroenterologist? Is it something that maybe I need a colonoscopy to make sure there's no colon polyps or colon cancer, which are causing these concerning symptoms? So for younger population who are worried, like I might not be in the screening age group, listen to your body and make sure to look for any alarm symptoms. So when we say colon cancer is preventable and treatable, we are talking about the screening test. And as I mentioned, you'll keep hearing the age 45 and above, because 50 is so old school. 45 is a new thing in. So when we talk about average risk patients, what we mean by average risk patient is there are subset of patients who fall under high risk for colon cancer. Those patients are either there's a strong family history of colon cancer or hereditary colon cancer syndromes, and patients with a history of ulcerative colitis or Crohn's disease, who we commonly come under the umbrella of inflammatory bowel disease, they are at a higher risk for colon cancer. And also, so for them, the screening starts at an earlier age. For example, if I have a parent, either mother or father, who was diagnosed with a colon cancer at the age of 45, I become high risk, and my screening starts 10 years from the age of when my parent was diagnosed. So it's like my screening starts at the age of 30. 10 years prior to the age of the index case in your family. And for patients who have Crohn's disease or ulcerative colitis, you have to talk with your gastroenterologist to see at what point in time, whether it's 8 years or 15 years since you were diagnosed with Crohn's disease or ulcerative colitis, then you would start falling under the umbrella where you need to start getting your screening colonoscopies to look for precancerous lesions. So when in doubt, talk to your primary care and then see if you need a referral to your gastroenterologist. So again, these statistics are staggering. We see that close to 100,000 new cases of colon cancer, of which 46 are rectal cancer, and you can see it's equally distributed between men and women. So please understand that it does not show any preference to males or females. So if you have a colon and you're at an age of 45 or high-risk family history, make sure you get your screening test done. And also, when you look at the data, you see that colon cancer diagnosis, colon and rectal cancer diagnosis has like kind of dropped off in elderly population. And we can say kudos to the screenings that we've been doing, the preventative screenings that we've been doing all these years. However, there is, because of all the screening and also change in lifestyle, mostly the smoking and alcohol and physical activity and so forth, but there's also a staggering increase in the amount of colon cancer, like precancerous lesions and the colon cancer that have been diagnosed in younger population. So if there's a downward trend in older population because of the screenings and change in lifestyle, but then younger than 55 of age, there is an increasing rate of 1 to 2%. So that is the data which has guided us to bring down the colonoscopy from 50 to 45. And the overall lifetime risk of developing colorectal cancer is 1 in 23 in men and 1 in 25 in women. And we can expect colorectal cancers to cause close to 50,000 and plus deaths during 2024. Those numbers are staggering. And what we need to understand is it's preventable, treatable, and curable. So that's where the whole consensus of Colorectal Cancer Awareness Month lies. So you can ask me, what does it mean to me? So when we are saying we need to do screening, there are different ways to screen for colon cancer, which I'm going to go in. You need to understand when we say preventable and treatable, look at the survival rates for 5 years for a diagnosed colon cancer. When it is at a localized stage, can you see my arrow? Okay, I lip read very well, so I can hear you. We can see the arrow.
You have two children, like, you know.
So if you see this, you have different layers of which makes up the walls of the colon. And what we are doing when we do a colonoscopy is we are looking at the inside of the walls of the colon. Imagine like a sausage casing. We are looking at the inside of the sausage casing or inside walls of a balloon. And anything that is within these confines are considered as localized, which means the survival rate when we do diagnose early cancer, we are not talking about precancerous lesions. We are talking about actually diagnosed cancer, colon cancer through colonoscopy. If it is localized, Dr. Arjun and all the colorectal surgeons can go in, take care of it, and the oncologist in lieu with the multidisciplinary team and oncologist for localized, the survival rate is 91% for 5 years. Regional is when, yes, it's gone through the walls and it's spread locally in the, like right next to it. Again, that's a good number. It's 72%. But once it goes past the colon into the further lymph nodes or into the liver or to the other organs, which we called as distant, it's about 13%. 13%, again, is a good number in terms of 5-year survival rate for a patient with metastatic disease, because that's a lot of time that you can do things that you would want it to. That's a lot of time to spend with the family, see that child of yours graduate or all that. So when we say 13%, as much as it looks like less than 20%, it's in terms of times that we get to have and spend with our family and friends. So when we look at the localized and regional, all the more incentive for us to know that, hey, you do undergo a colonoscopy. We are seeing a diagnosed colon cancer. The survival rates are excellent once we catch it early. So that is something that we need to understand, that colonoscopy is the best tool to go ahead and get screened for colon cancer or get diagnosed for colon cancer. So you might ask me, what are all the tests that we need that is available out there for colon cancer screening? There are several tests, and the concept of colon cancer. The colon cancer starts off as a polyp. A polyp is a bunch of unregulated growing tissue. If you look at this is again the walls of the colon. It comes up as a small blip or bump. It could be as small as 1 millimeter, or it could be as large as 2 to 3 centimeters or 5 centimeters. So they proliferate and become polyp. Polyp are precancerous. So when we do colonoscopy and we find that polyp, we can remove that polyp. Thereby we are preventing, because if that polyp, you see, these are the polyps. If the polyp is left to proliferate and goes through different changes called dysplastic, metaplastic, high-grade dysplasia, it kind of becomes malignant. And when it becomes malignant, yes, if it's still localized, they can undergo surgery and take care of it. But before it can become malignant or any malignant changes, when we go in and do a colonoscopy, we are able to stop that progression by removing the polyp when you're getting the colonoscopy done. So that is why we say get screened for colon cancer. And there are other tests such as, and I would like to say that colonoscopy is gold standard, where it's diagnostic as well as therapeutic. When I say diagnostic, you go in, you see, you find a polyp, it's diagnostic. And when I say it's therapeutic, I remove the polyp, we are taking care of the polyp. So it's therapeutic. So it's a gold standard test where you can take care of the polyp then and there and make sure that it's taken care. The other tests that are available, which we normally say non-invasive, are the stool test. So there is like different kind of stool test. One is the FIT test, the other one is the Cologuard, where it tends to see tissue, the precancerous tissue in the stool. These tests are very sensitive and very specific. And you might have seen in the advertisements where you have this colon bringing the poop box, the Cologuard advertisement, where it gives you to, it asks you to collect the stool and you send it out, and it looks for this immunochemical test to see either blood or the DNA, which is specific for the precancerous lesions called the polyps. When that test comes back positive, it's called a screening. You have screened the patient for colon polyps or colon cancer. So when it comes back positive, for all that we might know, there could just be a polyp, or it could be a colon cancer itself, early stages or whatnot. So the next step, if it's negative, then you just repeat it in the next 2 to 3 years and then go from there. But if it is positive, then the next step is to do a colonoscopy to see whether, hey, the test came back positive because we saw the polyp. And when we went and did the colonoscopy, we found the polyp. Hey, we removed the polyp, all good. And depending upon the kind of polyp and depending upon the size, we tell you how soon you need to come back for another one. But if we go in and the polyp, it's a cancer tissue, we take biopsies and then we set up the patient to see whoever needs to be seen to take care of it, either remove it or see the oncologist, depending upon the staging. So as much as there are screening tests available, I would recommend colonoscopy as a gold standard because, as I mentioned, it's diagnostic and therapeutic. And when you do a colonoscopy and there are no polyps, then you're good for 10 years. You don't have to come back in 2 or 3 years to get those other stool tests done. So it's like you're all clear, you're good for 10 years if there's no family history. If you have a high-risk family, then it's 5 years. Whereas the other test, as I mentioned, as much as if there are certain patients that I come across who are very scared to undergo sedation, have multiple other comorbid conditions, cardiac or lung issues, where they can go through the regular anesthesia for the procedure. Yes, we can start off because any screening test is better than no screening. Because if we find that the screening test is positive, the stool test is positive, then we can always recommend the colonoscopy, weigh the risk and benefit, and go from there. And again, what I want you to understand is colonoscopy, the screening test, there are stool tests that can be done, but if the stool test comes back positive, you need to get a colonoscopy to make sure, are we looking at a polyp or are we looking at a colon cancer? If not, the gold standard is the colonoscopy, wherein if we see a polyp, we remove it, it's all done and good. If there's a cancer, then we are going to take care of it and set up and make sure the patient has follow-up. So as I mentioned, colonoscopy is to check all the way from the rectum. This is the large intestine. This is around 5 feet, and that's pretty much what we are looking at. And anywhere a polyp can form or a colon cancer can happen if the polyp is not removed. So as I mentioned, we do have the stool test, which is called 2-step, because if the stool test is negative, then you repeat it after like 2 or 3 years. If the stool test is negative, is positive, then you have to come for a colonoscopy. Or we can just go and get a colonoscopy done and go from there. And what is the age of screening? We start at the age of 45 to 75. And after 75, it's up to the patient, the primary care, because I've had patients who are 80 and they can like race me and win multiple marathons, and I will be short of breath compared to them. So if they are, if you know that their life expectancy is going to be 10 years from there on, and they would want to make sure everything is good, because there are patients who say, Doc, I've completed all my screenings, my blood work, annual, like clockwork. I want to make sure I'm not missing anything. And if they want to get screened, we can always offer the stool test, or we can offer colonoscopy, but it has to be combined decision making sure the patient understands the risk and benefits and go from there. Let's go to and the other common thing that comes up is with the colonoscopy is bowel prep. That's the worst part. If you take the whole colonoscopy, unless there's a complication which is far and few in between, the worst part of the colonoscopy process itself is bowel prep. But I can tell you that the bowel prep has improved in the last few years. And there are different, different doctors or endoscopists use different kind of bowel prep. And sometimes patient might have other comorbidities, which might not give a good prep. So it's always good to follow the instructions, because we know you might think, okay, I just will do half of what is said, consume half the amount, maybe eat breakfast in the morning, not follow instruction. The doctor's not going to know. We will know the moment we go in. We will know who has done the prep and followed the instructions. And yes, there might be like less than 0.5% who might have followed everything, but they might have slow transit, constipation, and they might not be cleaned out. But 80% of the time we would know, because when we go in there, the walls would look sparkling and shining, and we don't have to spend a lot of time trying to wash, because the polyps are, if this is the colon, the polyps are on the walls. And if there is any sediment, or if there's any like residual poop, it's going to be very difficult for us to say all clear. And we might have to say, why don't you come back in a year? Why don't you come back in like 3 months, so that we can do a different prep, which means we would be giving you more volume to drink. So if there's any questions of whether I'm doing the prep right, it is, you can always like, the question that I ask my patient is, did you pee through your butt? Which means if your poop after the prep is like you peeing, your prep has worked and it's going to be a clean colon. And I've also embedded this podcast from Gastro Girl, and they talk about bowel prep and what are the concerns that patients have. Why should we follow? When should you talk to your doctor? What kind of preps are available, whether the insurance will cover it, because some of them are just over the counter. The preps that we use on a regular basis is Miralax and Gatorade along with Dalcolax. And those preps are over the counter. You don't need a prescription. And most of them insurance is covered, but there are other preps like Movie Prep or Half Lightly or like Sutaps or Soup Prep. Those preps, some of the insurances will cover, some of them might not, and it can be anywhere between $70 to $250. And if you don't want to spend that much for a bowel prep, there are other ways that you can use coupons or try to talk to your doctor to see, hey, how do I go about it? I'm worried that I might not do a good bowel prep. So that is something that you definitely need to talk either to the patient navigator in some instances, or the GI nurses, or the physicians that you see who sets you up for the colonoscopy. The other thing that I wanted to talk about the prep is make sure that you stay hydrated during the prep. And this one is for patients who tend to do plant-based or on plant-based meals, who are used to eating high fiber diet. Remember that it takes 54 to 72 hours for your colon to completely cleanse. So it's not the breakfast the day prior or the dinner 2 days prior. It's like 3 days of meals or food that you're eating, which is going to, which the prep is going to help cleanse. So if you're in a habit of eating a lot of seeds, or if you're in a habit of eating high fiber, the way that the prep works might not be the same. There might be some residue, because you need to understand the plant fiber doesn't get completely digested. You will see some of the residue coming in, and that's what forms the bulk. So coming through your colon. So which in turn again will clog the scope, will not be the visualization is not going to be good. So patients who follow like high fiber and plant-based diet, try avoiding nuts for a week, the small nuts. You can still eat nut butter. You can like do smoothies as long as the nuts are like completely powdered form. Powdered form is better, or ground form is okay. But a lot of these chia seeds and sunflower seeds tend to clog the scope. That's number one. Number two, try to at least go low fiber 3 days prior to the procedure. So that's the best way to get a good colon cleanse if you're on plant-based nutrition. As I mentioned, you can still do the nut butter. You can do like nice cooked vegetables, but raw vegetables with a lot of rough veg and seeds which clog the scope. Try to avoid 3 to 5 days prior to the procedure. Does anybody have any questions? Am I going too fast or?
No, you're doing fine, Vani.
Yeah,
I just wanted to add a couple of comments. So one is this: I get patients who are on a plant-based diet, and I suggest them that they just eat cooked vegetables instead of raw vegetables. And for the last couple of days, they could just do more smoothies rather than trying to eat solid food. And I've had several patients with plant-based diet come for a prep, eating their usual stuff until like 2 or 3 days before, and they had really good clean colons. And I wanted to stress the importance of doing a good job with the prep, because as Dr. Vani was saying, sometimes we just have to say it's not good, it's not clean enough. You'll have to drink more and come back again. So yeah, that's it's good to do a good job with the prep once. Yeah.
Yes. And as I mentioned, it's prep is the worst part. There's a lot of preps. The preps before, it used to be go lightly, almost like a gallon, and it tasted like sea salt, but now it's more like Gatorade and Miralax, and it's a split prep. When we say a split prep is a standard of care where we do split the dose of the prep instead of drinking it all at once. The first one would start like between 4 to 6 the day prior, or the evening prior to the procedure. And then once you finish that, it has, after a 3 to 4 hour gap, you do the next half dose of the prep, or 4 to 5 hours prior to your recommended time of procedure. The reason being is it kind of flushes out the last bit of whatever residue is there. And also our small bowel, stomach, all of this tends to produce secretions and bile and whatnot. And that tend to coat, especially the right side of the colon. The right side of the colon tend to have more flatter lesions. And if there's a coating of yellow slime like bile and the residual secretions, it's going to be hard for us to see see and identify the polyps between the folds. So the second split half of the prep kind of washes all that away, so that the right side of the colon is as clean as the left side of the colon. Because understand, it's a 5 feet long colon. And then stressing again in terms of age for screening, it's 45 for average risk, and and it's no more 50. Make sure that you, if at all there's any alarm symptoms prior to you hitting the age of 45, just talk with your primary care doctor. And then we are going to move on to, hey, you're saying colon cancer, is there any way that I can reduce my risk? Either before my age for screening, or after I do get a colonoscopy, they found some polyps, or I had a colon cancer. What are the things that are within my realm that I can decrease the risk? So for any disease process, there are 2 kinds of risk factors. One is modifiable risk factors, and the other one is a non-modifiable risk factors. Non-modifiable risk factors it is what it is, and we have to deal with it. Age is one of the non-modifiable risk factors, and colon cancer, as we increase in age, the incidence of colon polyps or colon cancer increases. Racial and ethnic background, especially in the United States, African Americans and Hispanic population tend to have more colon cancer, like polyps and colon cancer, than the other population. Male, I put it as sex over here, non-modifiable. It is not the incidence, but the aggressive nature of the colon cancer. Men tend to have more aggressive polyps, pre-malignant lesions, or colon cancer. So between male and female, the incidence is the same, but the disease progression is more or worse in males than in females. And then again, non-modifiable is history of ulcerative colitis or Crohn's, personal history of colon polyps, and family history and their hereditary symptoms. What are the modifiable risk factors? And that's where this whole lifestyle medicine thing comes in. The modifiable risk factors are cigarette smoking, alcohol, nutrition. When I say nutrition, that's very close to my heart. When I say nutrition, there are high fiber diet seems to be protective of forming colon polyps or colon cancer. If I flip that, it's more probably causative is high fat and low fiber diet and red meat consumption. So if you want to reduce your risk of colon cancer with the modifiable risk factors, then alcohol, cigarette, low physical exercise, high fat, low fiber, red meat, all these predispose or increase the risk for colon polyps, which are precancerous lesions, and colon cancer itself. So modifiable risk factors, the main ones are nicotine, unhealthy food choices, highly processed food, low fiber, red meat, lack of adequate physical activity, and excessive alcohol consumption. And that is sometimes we might be in a culture where daily drinking is okay as a part of winding down, but it has an additive effect where alcohol is shown to be causative for many types of cancer. So if there's one thing that you would want to, in terms of, and also it disrupts the gut microbiome. So if there's one thing that you would want to, you have to reconsider your alcohol consumption, maybe just a glass of wine at the end of the day, once or twice a week, or no alcohol, if you ask me. And then, as we all know, we have the standard American diet where 62% of the calories come from processed food, 26% of the calories come from animal product. There's absolutely no fiber. And the standard fiber requirement is close to 38 to 40 grams in males per day and 25 to 30 grams for females. And if hardly like 10% of the population meet the requirement, and it's always less than 5 grams of dietary fiber that we ingest. And that itself is like something that we are offsetting the risk factor. And the reason why I keep stressing on fiber and the nutrition is it's one of the modifiable risk factor which can be applied at every level of prevention, right from the primary prevention, secondary prevention, and tertiary prevention. When I say primary, yes, if you make sure that you meet your dietary requirements, avoid red meat, try and eat more fiber, vegetables, plant fiber, and cut out processed foods, ultra-processed food, that's primary prevention. Secondary is, yes, we find a polyp, we remove the polyp, there's an early cancer, we take care of it. And after that, to like, what do I do for my gut health? Again, all the modifiable risk factors can be applied at every single point in the prevention. So nutrition, diet, physical activity, and smoking, alcohol, at every level of prevention. Once you try to make healthier choices, even though the impact there's no direct causation in some cases, it's always additive towards better gut health. And it's the same slide because we are not meeting. This is the slide which shows that we don't meet the recommended limit in terms of vegetable, fruits, whole grains. We take more of meat and all that. And I already went through this. So why do we keep talking fiber and nutrition? Because fiber forms the bulk and it regulates the BM. And as regular as your BM can be, if there's any changes that happen, like you start getting constipated all of a sudden when you like clockwork move your bowels every day, that is change in your bowel habits, or you start noticing blood in your stool. So there's something that is, instead of moving your bowels once in every week, where you might think, okay, that's my normal, which may be normal, but it's not good for good gut health. And the other thing is fiber, as I mentioned, it regulates your bowel, it helps with constipation, and fiber is shown to be protective against colon cancer. And the way that it works is we have different kinds of fibers. There's soluble fiber, insoluble fiber. All of them are not made in the same way. So you need a good mix of soluble and insoluble fiber. And what does a soluble fiber do and insoluble? And this is where you need to understand the soluble fiber tends to like lower the cholesterol, helps to improve the glycemic index. And this is the example of all those things that have soluble fiber. For colon health, we need a good dose of insoluble fiber where it forms the bulk. And also fiber in general, I'm just going to skip this because I think the slide deck will be shared. Dr. Shobha will have the slide deck. So these are the things where, what does it mean to say whole grain? What is like processed? Because people will say, oh, I eat wheat bread, but it's stripped off. As long as it's stripped off of its fiber, you're not getting the fiber content. You're just getting a processed bread. So those are the things that you need to understand when reading the labels. And there was one thing that I wanted to, because I know we need to wrap up in a bit. Okay, so when we talk about colon cancer, gut health, and gut microbiome, everybody is born with a gut microbiome. And that kind of like changes once a baby is born, exposed to antibiotic, different foods, stressors, physical activity, life changes, the environment that you're growing up. All this contributes to shaping the gut microbiome. And whenever there is insult to the gut microbiome, and these gut microbiome tend to keep the colon walls healthy, and they derive their nutrients from the fiber, the plant fiber, because that's where whenever we eat fiber, it gets broken down and it forms a short chain fatty acids. And that is available only in the plant fiber. And these short chain fatty acids help with the colon gut health. And that is a reason we keep saying, how does fiber help? The fiber helps in the way of forming the short chain fatty acids, which are nutrients to the gut microbiome. And there's like a whole world that is exploring the gut microbiome, the gut-brain axis, and the disease process. And everybody keeps talking, everything starts in the gut. A lot of studies happening, and hopefully we have something to lean into and help our patients. But the bottom line is eat more fiber. And when I tell my patients to eat more fiber, eat more plant fiber, and depending upon if you have disease condition, you definitely have to talk with your registered dietitian, because some patients might have colon, which might have undergone surgery. So they might not do well with certain kind of fibers. So other than that, if there's no other comorbid conditions and you just want to eat more fiber, make sure that you eat like a rainbow kind and start off slow. You can go off and eat 30 grams of fiber in one day because your colon is not used to that bulk. Your colon is not used to that roughage. So what's going to happen is you are going to feel bloated. And on day 2 to 3, you're like, nope, I don't want to do this anymore. Every time I eat fiber, I feel so bloated. I feel like full. I feel gassy. It's not a good feeling. But you need to understand your colon has not handled that much of fiber all these years. So you start off as 5 grams of fiber for a week, then go up to 10, go up to 15, just space it out. At some point, you will hit a sweet spot where maybe between 15 to 20, you're meeting your fiber and roughage requirement where your bowels start regulating. And for fiber to work and help with constipation, we need water. Water and fiber, they go hand in hand. So make sure that you're hydrated good so that the fiber can work and help with constipation and regulating your BM. So that's all about the gut health and how do you get all the gut health thing. And most of the patients tell me like, there's so much, I don't know where to go and look for resources. I feel that eating fruits and vegetables are boring, and they might have not learned ways to incorporate. So there are a lot of resources that are available, and Gift of Health is one such wonderful resource where they actually provide community with recipes, cook-along demos to how to slowly include plant-based nutrition into your daily lives, and also help with the other aspect of lifestyle pillars. And some of my patients say it's too expensive to buy fresh produce. Guess what? The frozen spinach, the frozen mixed vegetables, the frozen carrots, peas, they hold the same nutrition. So and they're not going to get spoiled within a week if you're not cooking them. So you can buy them in bulk in Walmart or wherever the local groceries, or when it is seasonal, you can buy them in bulk and clean them up and put it in the deep freezer to be used later. And they hold the same nutritional value. They are less expensive. And when you start buying fruits and vegetables which are seasonal, the price does not add up that much. And what better price to gift yourself the gift of health versus the gift of disease, which is going to be more expensive in terms of medical expenses and insurance and premiums. And let's see. So how do we break down these barriers is doing the educating healthcare professionals, providing information, resources, and group visits, and all that. And what I would want to ask is, once we do all these screening, there are patients who we diagnose with colon cancer, and we send them to our surgeons. And I really would like Dr. Arjun to talk as to that side of the aspect, because once the patients are diagnosed with colon cancer and they go to surgery, I see them back after a year for their surveillance colonoscopies. So I would want to listen and learn from that journey too.
Absolutely, Vani. Thank you so much for that wonderful summary and presentation. Beautiful job. You covered so much ground.
I had to rush. It was a lot, but I'm glad that we could do it.
Good, good. Yeah. Okay. If you could stop sharing your screen. Okay, excellent. Yes, yeah. Perfect. Okay, there were a couple of questions. I think we'll just answer these questions. Should a polyp always be removed? As here in Ontario, they are not always removed. So it depends. Not all polyps have to be removed. Some polyps need to be removed. If they are tubular adenomas or sessile serrate adenomas, they need to be removed. But if there's many times we do see quite a bit of small, tiny polyps in the rectum, which are most of the time these are hypoplastic polyps. These can be left alone. If I see several of them, I just take a biopsy of one or two of them just to prove that they're hypoplastic. The hypoplastic polyps can be left alone. Would you mind add anything you'd like to say or add, Vani? Or
No, that's pretty much the standard. Like there might be a number of hypoplastic small polyps on the rectum. We need to understand, we need to practice cost-effective medical care. And if we know for sure with constant practicing and seeing these polyps and visualizing, if we know that it's going to be hypoplastic, we sample them in the rectum, not on the right side. On the right side, we tend to remove because that's where sessile serrated adenomas, which appear like hypoplastic, happen. But in the rectum, yes, you can just sample off. And better yet, we are having more innovative technology where it's called AI in GI, where it combines with the looking at better visualization and identifying the polyps, and also technologies to where it can identify the kind of polyp that needs to be removed and kind of polyp that can be left alone, because every polyp that we sample needs to be sent to the pathology, and that adds to the cost that the patient has to bear. So those are the things that we need to be very savvy about. And that's pretty much the standard of care too, Arjun. What you say?
Yeah. Oh, you got muted, Vani.
Yeah.
Okay, now.
Yeah, that's it.
Okay, perfect. Okay.
Yeah.
So there is another question. I'd like to see if you like to answer this one. Do you have any suggestions what to do if there is a large amount of FODMAPs and nightshades that affect your gut health negatively?
So I do believe that FODMAPs work well for subset of patients with irritable bowel syndrome. And I also want to understand every patient is an individual. So whenever it comes to their dietary, as long as they are not allergic to a food wherein, somebody eats pineapple and their mouth starts to itch, or they have lip swelling, like allergic reaction, or to the nuts, then that's you got to avoid it, see the allergy specialist and go from there. All other foods, it's like you try them, see how you feel. And if you start noticing a pattern, that's where the food diary or food journal comes in. As annoying it would be to start writing down and tracking, that's the best thing that you can do for yourself if you want to improve your gut health. Because you cannot say, we are going to do this for the entire population and make sure it works. It may work for some, it might absolutely not work for you. So if you want to think, should I try FODMAPs? I would rephrase and try to see, should I try a vegetable which falls under nightshade and see how I feel? Write it down. Try it in a different way, because the way that you eat, whether it's raw, the way that you eat it along with other things, the way that you cook, everything goes into how it makes you feel. And I would not abandon a whole food group saying that, oh, they said nightshades are something that's going to cause allergic reaction. No, you need to try to see how your gut behaves, how your body feels, and then go from there. If you feel terrible every time you eat eggplant in any form, shape, or thing, avoid it and move on to the next vegetable. But I would not say, I would not try this because X, Y, and Z said these are going to cause inflammation. As I mentioned, everybody is born with their own gut microbiome, and it changes over the years. As long as you're allergic to, like celiac disease patients, they are allergic to wheat, and wheat is a complete no-no. For them, I would not say, hey, try it. For them, it's no. And then they have to try to do other ways. But everything else, if you're not allergic, go ahead, try it, and maintain a food journal, and it'll give you a lot of clarity of how your body reacts.
Excellent.
Wonderful, Vani. Yeah. Just I wanted to add one more thing. What I found helpful for my patients who are struggling with food sensitivities, food allergies, FODMAPs is try to focus on what is that you can eat rather than what you can't eat. In the journal, like most people focus on, oh, I can't eat this stuff, I can't eat this stuff. But if you just shift your attention to what is that you can eat, you'll notice that Mother Nature has provided you with like hundreds and thousands of food you can eat, and you'll do fine with that. And one more thing is this, we have seen this again and again when people go through Gift of Health program, when going from all kinds of diet to a whole food plant-based diet, their gut microbiome changes. Even though they had like a lot of food sensitivities before, food allergies, like within 2 to 3 months, like all these food sensitivities and food allergies, like, they tend to fade away. So yeah, there is hope. Like if you need help, like you may have to work with someone who can help you step by step, but focus on what you can eat rather than what you can't eat.
So here we have a question. How long do I wait to check a food reaction?
A few hours or a day?
Or a
That's
day.
a part Neelam is asking.
So So as I mentioned, what was the question again? Food?
How long do I wait to check if I'm having a food reaction? Is it a few hours or a day?
So it's a very broad question about food reaction. So the food reaction, as I mentioned, could be allergies or it could be insensitivity. Allergy is something that you would know right away. And in some cases, allergy could be from the time that you ingest and it gets out of your body, which is like a couple of days at the most if you have a regular BM. And when I say reaction is you have some people eat mushrooms and they get like this queasiness, and once you move your bowels it kind of feels fine. Some food poisoning kind of a thing where you have reaction is once you start throwing up, you have loose stools. So those are like what we call as allergy or food poisoning. But when you say reaction, if you can let me know what you're asking in terms of reaction. Are you saying that, hey, I eat this food and I don't feel good? Or a lot of people say brain fog. So as much as we would like to blame the foods that we eat, we need to be savvy of choosing the right ones. And a lot of us don't know what are the different kinds of greens, vegetables, and fruits that are available out there, because we have been grown up in a culture where fast food is around us. If you drive down a highway, you'll see like 15 different fast food restaurants offering the same menu over and over again. So that is what we are tuned to in terms of, food choices. So once you go outside of that and try to explore more with some guidance, you would be able to understand what foods are good. And it would be nice at some point we have precision nutrition where they look at your microbiome, they look at your genetics, and they'll say, these are the foods that you eat to live 120. You're not going to get any reaction. That would be wonderful, but that is far out. There are studies happening that's far out. As long as you don't have allergies, I would recommend trying it out, see how you feel the next couple of days, have a food journal and go from there, because everybody reacts different way to different foods.
Thank you.
I hope I answered a question.
Yes, you
Wonderful.
did.
Yes.
You did, Vani. Yes.
Excellent. Yeah.
Yeah.
So we have a comment from Linda. She's saying, you two look younger and more beautiful each time I check in. Knowing and doing is my challenge.
Oh, man.
Thank you, Linda.
What do I have to say to Linda so that I can be added to that too? Now I feel left out.
Probably she's seeing you for the first time, Vani, but we can say that you look younger as well, because we have seen you before.
Okay. I'm just going to take it.
Okay. 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 I just want to honor the time as well. But I'm going to take few moments to share quickly some of the stuff that I see and do in my practice. I'm going to share my screen. Okay. So, Dr. Vani, she covered so much ground. So I'm not going to go into the stuff that she talked about, but these are some of the things that I see. See, almost all cancer, they start in polyps, and these polyps are beautiful. Like it looks like a strawberry, and it has a nice stalk. And people think that it's crazy people who think these things are beautiful, but it's the insides of us, like the gut and the stomach and all organs. These are some of the most beautiful design and architecture that we have. So this is a polyp with a stalk, and yes,
you go ahead.
Okay, just give me a second.
Mm-hmm.
Okay, yeah. So this is something that we remove these things endoscopically. This is another polyp. This is on a stalk. This is before, and this is after. Like you could see, it's all flat. This is another polyp, a growth that is coming from the bowel wall. This is after the polyp is removed. it's amazing that we are able to do these things as gastroenterologists, as surgeons. Like even a few years ago, these technologies were not available. Like that, we could not take out these polyps endoscopically, and the small polyps left alone, these things they turn into cancer. The chance of having a cancer in a polyp that is less than centimeter is like less than 5%. But as the polyp size grows to more than 2 centimeters, it's almost like 30%. And if there is something called villus component that shows up on microscope, it increases the risk of cancer even more. So to be able to do this procedure, and this is another polyp, and then take out the polyp endoscopically. This polyp is called a sessile polyp, where it is flat. Again, the whole polyp is removed endoscopically. Now, we're going to share some cancers. Like, you see these small polyps that we were taking out. And if these were left alone over a period of like next 3 to 5 to 7 years, these things can grow bigger and bigger. And here you're seeing a mass, colon mass, and the biopsies confirm that this is a cancer. Here it is showing up as a protruding thing. And I had another patient where it is showing up as a deep ulcer. This is another patient who had like a colon cancer, and this is this big mass. Again, it's a colon cancer. Another patient, and believe it or not, as Dr. Vani mentioned, and I mentioned in the beginning, some of these patients were actually in 40s and 50s. And when I did the workup, like to see if they had any metastatic disease, that means if there is any spread, like majority of them don't have any spread, but about 10 to 20% of them on the initial CAT scan itself, they had spread to the liver, putting them in a stage 4 disease, as Dr. Vani said. Once it becomes stage 4, the 5-year survival goes down from like, stage 1 or stage 2 being like 70 to 90% to 13%. So the good news is these things are preventable. Like these colon cancers, in majority of the cases, I'm not going to say every time, but from what we know, based on the science and the information that we are sharing, almost 80% of these colon cancers are preventable. That's what the data is showing. That's what the science is showing. And a big part of this, what increases the risk of colon cancer is the diet and lifestyle. I like to call it lifestyle link, and some of the things that Dr. Vani already mentioned. I'm not going to repeat them, but it's very, very important that you focus on fiber. People are so obsessed with eating more protein, like planning their meals around protein. But one thing that I want you to obsess about is, have you had enough fiber? Did you eat enough fiber for breakfast, lunch, and supper? So this is a rough idea of like, how we suggest our students, the Giftofhealth students, eat, planning meals around a lot of whole grains and starches and beans and lentils, and then eating lots of vegetables and fruits, and keeping the processed plant foods to minimal, and nuts and seeds also minimal. As you can see, there is no role for dairy or meat, but if you want to include them, like, use them sparingly. But this is eating a high fiber, whole plant-based foods has shown to not only decrease the risk of colon cancers, but also a whole host of other chronic diseases like heart disease and diabetes and obesity, metabolic syndrome. One of the thing that we see typically in our Gift of Health students is like they within few days of changing their diet. Did we stop sharing? Yeah. Within few days of changing their diet, they notice that they're losing weight, they're having more energy, and their bowel movements are better, and their blood sugar numbers are normalizing, and their blood pressure is normalizing. Acid reflux is one condition that gets better within a few days. Arthritis gets better. So it's not just one disease. Like when you start giving the right fuel for your body, your whole system starts undergoing rapid healing. Coming to the surgical aspect, like, what happens with these patients, like I've had, good fortune of actually removing several of these large cancerous polyps endoscopically with negative margins, and on the workup that they didn't have any um, uh, like metastatic disease, and these patients didn't need any additional surgery. I was able to just follow them every 6 months to then every year with a colonoscope, make sure that there is no recurrence. But these are small percentage of people. Then, if it is if the if it cannot be resected endoscopically, and if the cancers have gone down to the submucosa and the serosa, definitely, which are the deeper layers of the bowel, we do what is called a segmental resection or a partial resection of the bowel, and wherever it is possible, we'll try to hook the two ends back together. And most of the time, we are able to do anastomosis or hook the two ends back together, and patients have good recovery. But sometimes we are unable to, depending upon the location of it, depending upon some patient factors, we may, in a small percentage of people, we may have to bring the colon or the bowel in a bag. That's called colostomy. But that's only small percentage of people. And in majority of the people, this temporary colostomies can be reversed. But uh, the bottom line is this: once you go down the route of surgery, it's uh, yes, and with all the improved technology and the knowledge that we have, the outcomes have gotten better. But anything that you can do to prevent it in the first place is very, very helpful. And I want to conclude with one more thing: is this, even in patients who had colon cancer before and who have gone surgery or chemotherapy, changing their diet and lifestyle has shown to decrease the chance of having cancer coming back. So here we are not talking about just preventing the first hit of the colon cancer, but also we are talking about decreasing the chance of having a recurrence if you eat a high fiber, low meat, low fat diet, and also you exercise, keep your weight under control. One factor I think everyone should know is just the obesity itself. Like, if you're overweight, that, as research shows, that could increase the risk of getting colon cancer by almost by 30%. I think other factors Dr. Vani touched upon, like alcohol, then processed and red meats. See, the thing is, some of the things that are served on a regular basis in this part of the world, in US and Canada, like, sausages and bacon and ham and all these different kinds of meats, pork chops, and these things have shown, like IARC, International Association of Research on Cancer, like IARC, which is a research wing of WHO, World Health Organization, have labeled these things as carcinogens, right? These are not something that we take like lightly. So, on the other hand, like when we increase the intake of fiber-rich foods like whole grains and beans, nuts and seeds, fruits and vegetables, it there are so many mechanisms. Actually, just discussing the mechanisms itself, we could spend hours and days. Like, what are all the possible mechanisms? How meat and fatty foods could be increasing the colon cancer. I love physiology. I love how the human body works. And I spend hours and hours. Okay, if you eat cheese, you have high fat diet, then there are some bacteria in the gut. They increase the production of secondary bile acids, and the secondary bile acids itself, they are showing up to be carcinogenic. And I can go into each one of these, like, how, when you eat meat, how some of the meats, when you heat them up, it increases heterocyclic amines, and that increases the carcinogenesis. So, or sometimes it could be the heme iron. So there are so many mechanisms. So we could just do a physiology class on how meat increases the risk of cancer and how plant-based foods decrease the risk of colon cancer. So to summarize,
Yes.
stay away from alcohol. You reserve it for very special occasions. Special occasions are maybe Christmas or New Year. It's not every weekend. Okay, and then exercise. Exercise itself is showing up to be reducing the risk of colon cancer and rectal cancer, getting the weight under control, and making sure you're getting lots of fiber. Especially, like, I've done dietary histories in thousands of my patients. Unfortunately, many of my patients, I would say 90% of my patients don't get even 10 to 15 grams of my of fiber. It's shocking. Like, eggs and bacon and sausage for breakfast, and then ham and cheese sandwich for lunch, and then pork chops or shaken bacon chicken for a supper. The diet is primarily based on meats and the processed foods, and not much whole plant foods like fruits and vegetables, whole grains and beans, and these type of eating, it increases the risk of getting irritable bowels, Crohn's disease, colitis, constipation, hemorrhoids, and gallstones, acid reflux, and over a period of time, like a whole host of other diseases as well.
Yeah.
Yeah.
So I know, like, we covered so many things today, right? But like, what we want you to leave with, just if you just remember these 5 things from what we have covered today. So when it comes to colon cancer, it is preventable, treatable, and curable
Most of the time.
most of the time.
Yes. Yeah.
And it also depends on what stage it has been diagnosed, right? So when it comes, so colon cancer is a diet related disease. So what are the things that are causing colon cancer? So when we increase the consumption of red meat and processed meat, it increases the likelihood of getting the colon cancer. And the beautiful thing is we have control over what we can put in our mouth. And what we are choosing to put in our mouth is actually deciding whether it's deciding the likelihood that we may have of having this colon cancer. So the good news is we have control over it based on what we are deciding to put in our mouth. The other thing that can help us prevent colon cancer is getting the screening, getting the colonoscopy done. So as Vani was saying, 45 is the new 50. So 45 is the age where you want to get your colon screening done. And if you have a family history, you get it 10 years before. And the things that we can do to reduce our likelihood of getting colon cancer is increasing our fiber intake. So studies have shown it's actually directly proportional. The more fiber you eat, the more chances you're reducing the likelihood of getting cancer. But again, when it comes to fiber intake, it's just like going to gym. Like on first day, you cannot lift heavy weight, right? You know how much you can lift. It's the same thing with fiber. If you're not used to eating huge amount of fiber, and if you try to do that, it will just backfire. So know how much you have been taking and increase. So increase your fiber intake. Just go slow and low, and slowly you can increase your fiber consumption. And the other thing is the more whole food, plant-based foods that you're including, it's not only helping you with preventing colon cancer, but it is also helping you preventing other chronic conditions that we are seeing nowadays, right? So
I do want to say a couple of things that are more relevant to where we are in Newfoundland. In Newfoundland, we do have this guidelines for colon cancer prevention. We are not there yet where 45 is the new 50, that is more in US, but here we're still doing age 50, starting the screening from age 50. And we do have a Newfoundland and Labrador colon cancer screening program. I'm just going to share the screen here. I think you can find this online as well. Um, these are the clinical practice guidelines in Newfoundland and Labrador. Like, target population is 50 to 74-year-old. And if you don't have any family member who had colon cancer before, then you could be enrolled in this program, and you can get this FIT test, fecal immunochemical test. You can have it done every 2 years. And if the FIT is positive, then you need to have a colonoscopy. But if somebody has as a positive family history, like if you have a family member who was diagnosed with colorectal cancer before age 60, or 2 or more first degree family members who were diagnosed with colorectal cancer at any age, then you need to have a colonoscopy directly. you don't go for the fit test. Let's say if your fit test came back as negative, then you can just have like colonoscopy again in 2 years. So these are general guidelines. But let's say if you have polyps after the colonoscopy, then your doctor can help you decide when you should have the next follow-up colonoscopy. Okay.
If I may add, as Shobha mentioned, screening to prevent alarm symptoms if you're not 45 and there yet. And I would emphasize that every single person at least need to know a little bit of cooking and where your produce is coming from, because that's one life skill which will help you better your health at any point in time, and it'll also help to guide your friends and family. So as much as we feel that cooking is something that I don't have time for, just understand by knowing and learning about how to quickly put together, because 80% of my patients don't make healthy choices because they don't have time, or they haven't learned that skill where they are able to comfortably put together a meal which is plant-based, rich in fiber, because we did not grow up learning it. So at some point we need to unlearn the choices and try to learn basic skills of putting together a nutritious meal. And that'll go a long way. And being a mother of two, I always feel that is something that you can pass on to the next generation so that they don't end up with fatty liver or get diagnosed with colon cancer at age 30 instead of 45. So if there's something that you would want your kids to learn, teach them about nutrition and provide them skills so that they would be able to put together a nutritious meal.
So well said, Vani. You just hit the nail on the head.
Yeah, I tell my patients, you can either take time to take care of your wellness, protect your wellness, or you'll be forced to take time to take care of your illness. If and that if you take 15 minutes or 1 hour now, it will save you 10 hours later. So all the time that you don't have to waste while waiting to see doctors and having these tests and surgeries and all, you can spend all the time in the kitchen.
Yeah. And thank you so much, Vani, for your wonderful presentation. And like our community loved it. You have wonderful comments here, and they're thanking you for your wonderful presentation. And they got to learn so much. So thank you so much. And it was real. I mean, we had so much fun, and it was a real pleasure having you here.
You got to unmute.
Thank you so much for having me. It's always fun to watch what y'all are doing and how much it benefits your patients and community. Thanks for having me. Don't forget to talk about colon cancer screening.
Yes.
Wonderful.
Yes.